Well, hello and welcome to the Highlights podcast, summarizing the key messages from our recent webinar, Advancing Patient Care Through an Interdisciplinary Approach to IMIDs, Part 2. It's a little bit like the sequel to a great movie, isn't it? Well, let me tell you, this is one where the sequel was at least as, if not better than part one. It was absolutely fabulous. My name's Iain McInnes. I'm chair of the IMID Forum. And in my other life, I'm the vice principal and head of College of Medical, Veterinary and Life Sciences in the University of Glasgow in Scotland. And today I'm joined by Dr. Grace Wright, consultant rheumatologist, New York, and I think just the wonderful president of the Association of Women in Rheumatology, and Dr. Melinda Gooderham, a dermatologist and medical director at the Skin Centre for Dermatology in Canada. So, Grace, Melinda, lovely to have you both on board.
Happy to be here.
Yeah, thank you for the invitation.
Well, what a team, let me tell you. And you got to get across to this webinar, guys. It's on the IMIDforum.com. We just had such a lot of fun, and I have to tell you, I learned a huge amount. What we're going to do in the next short number of minutes is just highlight the key messages that are going to be contained and accessible to you in more detail. Remember, the full on-demand webinar is available on www.imidforum.com. You can watch it for free. Now, when does a Scot offer you anything for free? So listen, grab the opportunity as soon as you can. So look, Grace, as succinctly as you wish, do you want to highlight the 5 million new things I learned? The most important one, by the way, being that if you see data, you got to ask yourself, does Grace care? Okay, what were the data that you cared about, Grace?
Yeah, so two things. As a chef myself, cytokine soup is critical. Why? Because that's what our patients live in. And so what I really talked about was looking across the spectrum of our inflammatory mediated diseases, thinking about inflammatory arthritis, inflammatory skin, inflammatory gut. What are the pathways? How do they intersect? And then what are the guidelines about how I think about patients on the spectrum across all of these diseases? And then thinking of all of the new and ever emerging data that comes, whether it's nanobodies targeting IL-17A and F, whether it's long-term data sets looking at safety and efficacy across therapies that we've had now for some time, or it is in patients who have challenging disease or refractory to multiple therapies, or they're young or they're elderly and we're missing really complete data. We'd love to know how to sequence things, what to use first, then second, but we're working on getting there. But really just the strategies that we need to use to apply to manage a patient that walks into our offices every single day. There are things that we can learn here. And yeah, I learned so much as well, but thrilled to share some of this data.
And one of the things that really struck me, Grace, when you were going through your presentations, you were starting to think about the different pathways that are dominant in different tissues, so-called domains of therapy in the IMIDs. And the domains we were thinking about: skin, enthesis, gut, synovium, and we teetered into other really critical areas. Yes. The brain, for example, the metabolic system. So you highlighted that the domains may not all be pathogenetically identical, which is when we can get ourselves into trouble, as I recall.
Yes, for sure. And then to think about the damage that can occur in different domains at different points in that patient's journey to make sure that we think about those domains and address them critically.
And the problem we have with tissue damage is that the immune system has this irritating habit of recognizing tissue damage. It's called immunological danger. And right. That's why we have adjuvants and vaccines, to irritate the tissues so that an immune response sees a potential target, and in the context of damage, it says, this might be dangerous. I maybe better do something about it. And that issue of tissue damage turned out to be absolutely crucial. And we did think a little bit about, therefore, sequencing of therapies. But we also thought a little bit about when things become really rather complicated, Melinda. And you gave us a couple of cases which, frankly, demonstrated at one level how much we know, but at another, it's important to remain humble as pathogenesis-driven clinicians, and maybe you can reflect on the cases that you brought to us, and then the three of us, we can just have a chat about them. But they were perplexing, I don't mind saying.
Yeah. So both cases were females that presented with red, scaly scalps, and a dactylitis, but they had very different stories. So the first one is a 25-year-old younger woman with some anxiety who presented with scalp psoriasis and dactylitis, who was started on an interleukin-17 inhibitor with the idea to treat both her skin and her joints or her arthritis. So she did well initially. However, after 6 months of therapy, she developed diarrhea, which was diagnosed as new onset inflammatory bowel disease. So the discussion being, number one, is it possible that the IL-17 inhibitor had anything to do with this, or was this her disease in progression because she had, recently developed other domain involvement, including the skin and the joints? So her case, we discussed taking her off the interleukin-17 inhibitor and where to go next. Because of what was available at the time, I did switch her to adalimumab, TNF inhibitor, which was managing all of the domains she had involved. But there was some great discussion about 2025, what the options are now with JAK inhibitors and perhaps P19 inhibitor.
Yeah, no, absolutely. And yeah, it was actually quite interesting reflecting. Do you remember in the olden days when biologics were this incredible revolution? And now we're sitting saying, well, maybe that's not the best biologic. Maybe there's another. I mean, Grace, you did that. I mean, you just said, what, a TNF blocker? Surely not, Melinda. Well, maybe that's not quite what you said. Why don't you correct the record, Grace, and just make sure we're all telling the truth here, okay?
No, well, it's really interesting, right? As therapists evolve, your thinking evolves, right? And so I immediately said, what's going to cut across all domains? Well, go to signal transduction, because I'm a signal transducer type immunologist. And so I'm thinking of pathways that we can hit with one thing. But the other case that Melinda had was perhaps we might need to use a small molecule and a large molecule in combination. As we find the nuances in the way this incredibly sensitive immune system works. But yeah, because it was 25 years ago doesn't mean it's irrelevant.
Absolutely. Listen, I'm going to argue with nothing that's 25 years old, because it's my golf clubs, and well, now I think about it, they don't work very well, but hey, that's another story. It's nothing to do with their longevity. Listen, you've enticed our audience, Grace, by mentioning the second case. Melinda, why don't you just refresh our memory of that, and then we'll just think a little bit about the implications, because it was almost the inverse, wasn't it?
Yeah, so this was a patient initially with longstanding Crohn's disease who had failed multiple therapies over the years, including steroids, azathioprine, adalimumab, and she was finally stable on infliximab, but unfortunately developed very red, scaly, itchy scalp that was impacting the quality of her life significantly. And she also developed or had some arthritis, had a dactylitis. So the question was, number one, is this TNF inhibitor that's doing so well to control her difficult to manage bowel disease, causing an interferonopathy, and the interferon then leading to the skin eruption, which was itchy, and the discussion around whether when you find a drug that actually is managing the bowel, do you add to it, as Grace had suggested one option, or do you switch therapy? And we sort of talked about how we don't really know what's going on in these patients still. We have some clues and some ideas, but we don't fully understand.
No, absolutely. Grace, you had a few brilliant remarks. Do you want to just think out loud about that? I mean, this is a so-called paradoxical eruption, but when you really think about it, that's such a naive way for us to think about it. The paradox is that we think it's paradoxical, I suppose.
Exactly. And we identify things based on what we know. So something new comes up that resembles something, we call it the thing that we know. So we've talked about the psoriasis that's caused by TNF. Now we say a psoriasiform eruption, but it's being driven by a completely different pathway. And so we have to think outside of that box to say, well, it's actually a new inflammatory skin lesion that might resemble something we've seen, but it's itself completely new. And the same thing goes for the gut. When we see gut eruptions in the setting of immune dysregulation and immune re-regulation. So do we start to do combinations? taking something that works on the interferonopathy pathway, like perhaps a TYK2, while we continue with a biologic that was incredibly responsive for the other domains? Or do we switch and find something that works across everything equally well? And there's research that's needed in these areas for us to both understand the underlying mechanisms and then to think about how to disrupt them.
And I mean, in essence, what we're looking for are therapeutic interventions that capture as many of the involved domains as possible. And yeah, we have that now in JAK inhibitors and P19 inhibitors, 17A inhibitors, dual AF inhibitors. But also, if we're honest, we've got that in TNF inhibitors and some of our other small molecules that we've used for decades. What we're much less good at doing is matching the right choice of therapeutic to the right pathogenetic dominant pathway in any one individual. And, you know, I guess that's what we'd love to be able to do, is we'd love to be able to pick up those early lesions and say, if we interrupt now with the right perturbation, then disease progression will be diminished.
But Iain, I'm going to say we still then have to be humble to understand that that too can change. And the disease and immunology will change under us. And suddenly now we have uncontrolled in somebody who was well controlled for 10 years. What's that about, you know? So that's a humility in the absence of what we know.
Yeah, I think it's called the exposome. I mean, one of the things about my own thinking has evolved very rapidly is to try and think about why we're not doing better. Now, listen, that's a very Scottish thing, you know, the cup is half empty, the rain is all around me, but then it's the middle of July. Why wouldn't it be raining in the middle of the Scottish summer? It gets a young man to think this way. And truth is that we still don't really understand that glorious complexity. And, you know, you and by the way, head along to the webinar. Grace did this amazing job in laying out all the different pathways across the different involved tissues. That complexity is not there to baffle rheumatologists and dermatologists and gastroenterologists and pharmacologists. That complexity is there to maintain robust host defense against a potentially infinite molecular microbial world. So, you know, we're dabbling at the moment. Now, we're dabbling really effectively, and at no time would I want to diminish the incredible achievements in immune disease treatments of the last 15, 20 years. I mean, my goodness, when I think back to what things were like when I started in practice to what we now have, it is absolutely transformed. But, you know, success makes us greedy for more. We have so much more. And it's not just we as health professionals, as researchers, it's our patients, people with immune disease who are asking for more. We've given them sight of what might be achievable. And I think we have such a responsibility now to go ahead as shared disciplines. And that just brings me to the last thing I want to highlight from the webinar that was very impactful for me. Listening to Melinda talking about skin disease, listening to you, Grace, talking about joint disease and GI disease, I was struck once again about how much we have to learn from each other, and the huge value that is to be gained in immune disease specialists talking to each other, working with each other, with the patient at the center. Melinda, just maybe a brief thought in that area from your good self.
Yeah, I mean, one of the areas we didn't get to talk too much about just because of time was the shared decision making. And we talk about shared decision making as between the clinician and the patient. That's often how we focus it, but really there's multiple clinicians around one patient. So we have to make sure we're all on the same page, because that's also one problem when the patient goes to see 3 different specialists and they get 3 different stories or answers. That can be more stressful for the patient. And they don't want they don't want to say the wrong thing about the other clinician. So it's really that teamwork approach and being on the same page we all need to work on.
No, absolutely. Grace, your final thoughts on that same topic. I'm so pleased you brought that out, Melinda. Thank you.
Yeah, because ultimately it's the patient's quality of life that we're aiming to improve. And so we collaborate and share in that. And then the one other domain that I want to always focus on is mental health and wellness is patients will not ultimately get to their absolute best unless we consider the biology behind their mental wellness, as well as the importance that mental wellness plays in our immune-mediated inflammatory diseases.
Absolutely. So well taken. And that actually, Grace, was something that came through very clearly in our discussions. So look, for some of us in real privilege, we actually have combined clinics where 2-3 different specialists in Glasgow, we do run combined clinics where one person with immune disease will see a derm GI room all at the same consult. The reality around the world is that that's not the norm. And I think that shared knowledge that you both did such a beautiful job in the webinar in giving, the insights were so extraordinarily well delivered. And I know by those who go from this podcast and into the webinar will be very well received. I'm going to bring this short podcast to conclusion with just a little Hippocratean philosophy. It is far better to know the person that has disease than the disease that has the person. Now, lest Grace and all the other immune pathogenesis dissectors of the world rebel, of course we need to understand the disease as well. But the primary creed for us all as immune disease physicians and health professionals is to understand the impact that disease set has on the human being in front of us. So listen, ladies and gentlemen, if you want to explore that conceptually and with practical examples, please head across to the webinar and listen to my brilliant colleagues leading you, guiding you, and educating you. Thank you, Grace. Thank you, Melinda, for joining me today for this short podcast. Thank you also for the amazing information you gave us in the webinar. And with that, I'm going to hand back to you, our wonderful audience, listening to this podcast. We hope it's helpful to you, and we most importantly hope it's going to make a difference for our patients. Thank you so much.
Thank you.
Thank you.